This video presentation is about shoulder pain, how to make the diagnosis. I am Mayor Lloyd, Ireland, with the Department of Orthopaedic Surgery and Sports Medicine at the University of Kentucky, and it is with pleasure that I show you these slides, many of which are cases that I've taken care of over the years in my orthopedic practice. Examining the patient in a seated position is very effective. You can palpate the landmarks, the AC joint, the glenohumeral articulation, inferior luxation, and then anterior posterior, rocking the shoulder. So I've got my hand on the proximal humerus and I'm rocking in and out to get a sense of the stability going forward and backward. And now in external rotation, we bring him back in a crank test. If he has a labrum tear, this is our peel back position. So he would be hurting here, but also if he had anterior instability, he wouldn't like it much when you get him back in the externally rotated abducted position. Ask him if that reproduces his pain. Internal rotation can also, if you have a labral tear, such as a slap tear, the extremes of internal or external rotation by clinical exam can reproduce pain. Look for symmetrical motion as far as the rotation is concerned. Then we go to a supine exam. Make sure they're close enough to the side of the table so that you can palpate their humeral head. So into internal rotation in the upper left, and then into external rotation. So if she had anterior instability, she would be apprehensive in this position. And again, you're rockering the humeral head forward in that position. And then on the right is the seated exam. This is almost like a lockment of the shoulder, if you will. I'm holding the acromion, clavicle still, and then rockering back and forth. And even in a big athlete with significant development of their deltoid, you can get underneath and use your index or long finger anteriorly and rock them back and forth. And then if she has anterior instability, as in the lower right, she's not going to be very happy as I'm stabilizing the scapula, and this will cause her to have apprehension if she has anterior instability. Again, a supine exam, external rotation. You want to look for the passive range of motion when you're doing this. Some people grab the humeral shaft and will bring them forward, anterior, or backward. Personally, I like palpating more proximal, but this is our crank test, our instability test. So I bring my long finger deep to the deltoid posteriorly and then put my thumb on the humeral head and basically rocker the humeral head anterior and then posterior, anterior and then posterior, and you ask the patient what reproduces their symptoms. Look for symmetrical internal rotation and external rotation. Pictures typically have loss of internal rotation and greater external rotation. This is a case of a freshman football athlete at one of our college schools. Never had any problems. Opening game. Came out of the game stating his arm was numb, dead arm complaints. He thought that he fell on his shoulder laterally while being tackled. Clinically, he was unstable, had anterior apprehension. He had an axillary nerve palsy with numbness over the deltoid, but he did have motor was intact. He was not dislocated at the time of his exam. I did not let him go back into the game because of his weakness, because of his deltoid numbness and his instability. We got x-rays. This is a probable Hill-Sachs lesion where there's radiolucency in the greater tuberosity. However, we don't have an axillary lateral view. Here is our axillary lateral view. So regular view that we get is on the left. And do an axillary lateral view in external rotation as well, and you can better see the posterolateral humeral head compression defect called a Hill-Sachs lesion. This is a good view to get to look for on plain films the Hill-Sachs lesion. You can see the indentation on the modified externally rotated view, but not on the regular neutral or even internally rotated view. The coracoid is there on the right-hand side of this x-ray. MRI scans. We did not use intra-articular gadolinium. This is blood that's on the inside of the joint from his dislocation. So acutely, we have our own arthrogram, if you will, because of the blood that's intra-articular. He did have a very significant Hill-Sachs lesion, 25%, and there was labral detachment of the entire anterior aspect of the labrum from the glenoid, indicating an anterior dislocation most likely that's self-reduced. This is pretty common in football. They may not remain out, so it's very important to examine them on the sideline to determine if they should return to play, because a redislocation is very likely if they've just dislocated even for the first or second time. Here's a C of the axial view, axillary lateral view, if you will, of the MRI scan. You see the biceps anteriorly, and in the back you can appreciate the Hill-Sachs lesion with what looks like a rat bite seen on the T2 image on the left. So this is the Hill-Sachs lesion, estimated to be 20% of the humeral head. And if you look at that wedge of the labrum anteriorly, there is a tear where the blood is between the labrum and the glenoid. Great view of thinking about what happens with an anterior dislocation of the Arthroscopically, first-time dislocator, we scoped him. He had an anterior instability event for the first time, had significant instability clinically, and had avulsed his labrum. Ideal opportunity to do surgery, and the indications are sound. This is in the lateral decubitus position, so we're looking from the scope in the posterior portal. And this is the significant injury that occurred with just one dislocation. So you see the heme in there from the hemarthrosis from the osteochondral fracture of the Hill-Sachs lesion, and also from the avulsion of the labrum anteriorly. The upper two pictures are great examples of his Hill-Sachs lesion. It's not that big a Hill-Sachs lesion, but this is the result of his anterior dislocation. So the lip of his glenoid anteriorly caused this fracture of the posterior lateral humeral head. But the most significant portion here to look at is the bottom two pictures, where there's significant articular cartilage injury to the anterior portion of the glenoid. You can see here all this peel back of the articular cartilage in addition to the labrum has been injured. And with newer MR techniques, we're better seeing the articular cartilage, but we didn't appreciate that there would be this amount of articular cartilage damage where it basically just peeled off. And if you think about this being a bumper out in the front for stability, his labrum is very beat up after one dislocation, and then we debrided this cartilage that was loose back to bleeding bone, and then did an arthroscopic repair. So the damage done with a single dislocation is often underappreciated by the physical exam, and MRI scans give us a lot more information about what's going on with the labrum and the bone.